Hello everyone. So as a part of the INI-CET revision series, the today's topic for the discussion is the disorders of the sodium balance. So one of the very important electrolyte abnormality which we come across in the hospital setup is the sodium, that is your hyponatremia or the hypernatremia. So I'll give you various clinical scenarios. Now you should identify what is the diagnosis or what is the etiology of that particular sodium abnormality. So starting with the first important clinical scenario. The first clinical scenario is a 55-year-old smoker presents with weight loss, hemoptysis, and as well as the confusion. Urine osmolality 520 milliosmoles per kg and serum sodium is 112 millimoles per liter. Now, in the clinical scenario which has been given to you, what is the abnormality? The abnormality is increase in the urine osmolality slightly and decrease in the serum sodium. So among the options which has been given to you, in which clinical condition you will come across this abnormality? So first of all, the individual is a smoker and there is weight loss, hemoptysis, and as well as confusion. So this weight loss and hemoptysis in a history of smoker is suggestive of a malignancy, and the confusion whatever is there in this individual is because of the hyponatremia, which is 112 milliequivalents per liter. So among the options which has been given to you, that is low dietary intake, diabetes insipidus, nephrotic syndrome, Addison's, SIADH, excessive sweating, hypervolemia or hypervolemic hyponatremia, insulin overload, chronic liver disease, pseudohyponatremia, ACTH secreting adenoma, hyperosmolar non-ketotic coma. So among the options which has been given to you, you will come across this clinical scenario in patients with the SIADH, syndrome of inappropriate antidiuretic hormone. So SIADH is the clinical scenario which is characterized by excessive production of the antidiuretic hormone. So because of excessive production of antidiuretic hormone, there is more and more water reabsorption across the collecting duct. So there will be development of compensatory mechanisms in SIADH, and that will induce the development of hyponatremia, right? That will induce the development of the hyponatremia. Now, what are the other causes? In this patient, what we are suspecting as the cause of SIADH is the small cell carcinoma of the lung. Small cell carcinoma of the lung, this is one of the very important malignancy that can cause the SIADH. Now, what are the other notable tumors that can cause the SIADH is tumors of the central nervous system, prostate tumors, pancreas, thymus, and as well as the lymphoma. Now, to make the diagnosis, the patients of SIADH should be clinically euvolemic. This is very important. In patients with SIADH, there will not be hypervolemia because of the activation of compensatory mechanisms. There will be euvolemia. So in SIADH, the patients will be euvolemic. There will be low plasma osmolality and there will be high urine osmolality. And in these individuals, there will be also hyponatremia. So if you see the classification of the hyponatremia, that is based on the serum osmolality, normal, low serum osmolality, and high serum osmolality. Now SIADH, it comes under low serum osmolality and euvolemic hyponatremia. So what are the differential diagnoses for euvolemic hyponatremia? That includes SIADH, postoperative hyponatremia, hypothyroidism, psychogenic polydipsia, Beer potomania, then idiosyncratic drug reactions like thiazide diuretics, ACTH, ACE inhibitors, endurance exercise, and adrenocorticotrophin deficiency. So now among the options which has been given to us, like we also have the ACTH secreting adenoma, but the diagnosis is very much suggestive of SIADH because you have an underlying etiology causing SIADH, that is small cell carcinoma of the lung. So the answer here is the SIADH. In patients with SIADH, there will be euvolemic hyponatremia, there will be increased urine osmolality and decreased serum sodium. This is a very, very important point. Now, how do you treat these patients with the SIADH? The drug of choice for SIADH will be Vaptans. Vaptans, these are the drug of choice. And if the individual has symptomatic hyponatremia, then you also need to give 3% sodium chloride. That is, hypertonic saline supplementation should be done. And there are certain drugs which can cause SIADH. What are those drugs which can cause SIADH? That includes an anti-epileptic drug, that is carbamazepine, right? First generation sulfonylurea, that is chlorpropamide, and as well as the immunosuppressant drug, that is cyclophosphamide. So these are the etiologies causing SIADH. So to summarize, in patients with SIADH, there will be hyponatremia, euvolemic status, and urine osmolality increases, serum osmolality decreases. That is what you will have in patients with SIADH. Then you take the second clinical scenario. Second clinical scenario is a 30-year-old man presents with symptoms of polyuria and as well as polydipsia. Plasma sodium 165, plasma osmolality 310, urine osmolality 190. So if you observe very closely, what is the abnormality that you are seeing here? Polyuria, polydipsia, increased serum sodium, then increased plasma osmolality and decreased urine osmolality. So where do you come across this clinical scenario of polyuria, polydipsia with increased sodium, increased plasma osmolality and decreased urine osmolality? That you will come across in patients with the diabetes insipidus. And diabetes insipidus, it is of two forms. One is central and the other one is nephrogenic. Central diabetes insipidus is that which is characterized by decrease in ADH secretion. Nephrogenic diabetes insipidus is that where there is resistance to the action of the antidiuretic hormone. And what is the investigation of choice for diabetes insipidus? That is water deprivation test. And what is the treatment? For central diabetes insipidus, the drug of choice is desmopressin. Right, we give vasopressin analog, that is desmopressin. And for nephrogenic diabetes insipidus, the drug of choice is the hydrochlorothiazide. So to summarize, in patients with diabetes insipidus, they will have hypernatremia and urine osmolality is decreased, serum osmolality is increased. That is what you will have in patients with the diabetes insipidus. Now you take the third clinical scenario. A 45-year-old man presents with type 2 diabetes mellitus and he presents with drowsiness and as well as the dehydration. Plasma sodium is 158, which is increased. The glucose is 720, which is also increased. So the individual is type 2 diabetic. The individual is having drowsiness and as well as dehydration. So in type 2 diabetes mellitus, with the glucose levels of 720 with plasma sodium of 158, which is nothing but your hypernatremia, you will see this in a complication of type 2 diabetes mellitus, that is hyperosmolar non-ketotic coma. So the answer in this question is hyperosmolar non-ketotic coma, which is a very, very important complication of type 2 diabetes mellitus. And the very important part of the HONC, hyperosmolar non-ketotic coma, is it is non-ketotic. That means the ketone bodies are absent. Because the ketone bodies are absent, there is no acidosis within the individual. And what is the first line management in patients with the hyperosmolar non-ketotic coma? The first line management is you need to give the normal saline. Always remember, don't give insulin first, either in hyperosmolar non-ketotic coma or diabetic ketoacidosis. Whenever you are giving insulin, insulin must be given with a care, because if plasma glucose falls too rapidly, there is risk of rapid change in osmolality causing cerebral edema, right? Causing cerebral edema. Now you take this anticoagulation, that is also indicated in patients with syndrome of inappropriate antidiuretic hormone, because these individuals, they are at risk of thrombosis. Because these individuals, they are at risk of thrombosis. So that is the reason why you need to give the anticoagulant. So this is about HONC, hyperosmolar non-ketotic coma. So hyperosmolar non-ketotic coma, it is a complication of type 2 diabetes mellitus there is no acidosis in this individual. These patients, they will have hypernatremia and hyperglycemia. The first line treatment is normal saline. Insulin should be given with care. And these individuals, they are at risk of thrombosis. So that is the reason why you should give anticoagulation as well. Now, you take the fourth clinical scenario. A 50-year-old person with type 1 diabetes mellitus and hyperlipidemia has mild hyponatremia. The plasma sodium, it is 125 millimoles per liter. So what is this clinical scenario suggestive of? So our patient is having hyperlipidemia and mild hyponatremia. So in a case of hyperlipidemia, having mild hyponatremia is nothing but your pseudohyponatremia. So what is the pseudohyponatremia? Pseudohyponatremia, it refers to spuriously low serum sodium, right? Spuriously low serum sodium caused by hyperlipidemia and as well as hyperproteinemia, right? Caused by hyperlipidemia and as well as the hyperproteinemia. Okay, so that is what is the pseudohyponatremia, right? Next, now after having discussed about the fourth clinical scenario, then you take the fifth clinical scenario. Hyponatremia associated with heavy proteinuria in a 55-year-old woman on long-term penicillamine treatment for rheumatoid arthritis, right? On long-term penicillamine treatment for rheumatoid arthritis. So now you take this penicillamine for rheumatoid arthritis, it can cause rapidly progressive glomerulonephritis and it can progress even to the development of the nephrotic syndrome. So among the options which has been given to you, the individual having heavy proteinuria, right? Among the entire options which has been given to you, the individual having heavy proteinuria, you will come across that only in patients with the nephrotic syndrome. So in patients with nephrotic syndrome, there is heavy proteinuria, and along with this heavy proteinuria, there is also hyponatremia. Actually, why there is hyponatremia in this individual? In patients with nephrotic syndrome, there will be edema. In the sense, there will be hypervolemia. So this hypervolemia is the one which is causing hyponatremia. So the hyponatremia, whatever you are seeing here, it is dilutional hyponatremia. It is not true hyponatremia. So the answer is the nephrotic syndrome. Now, how to calculate the amount of, see, you take in patients with hypernatremia. So that was about your hyponatremia. The last what I wanted to tell you is how to calculate the treatment of fluid that should be given in case of hypernatremia. See, in case of asymptomatic hypernatremia, like you need to give liberal water intake. But how much is that water that you should give in case of hypernatremia? That is liberal water intake. So volume of the fluid correction in case of hypernatremia is total body water multiplied by actual sodium minus 140 by 140. I'll give you an example for this. So you take a 60 kg female with sodium 160. So now how much fluid you have to give in this individual? See, how do you calculate this total body water? Weight of the individual multiplied by 0.5 is what is your total body water. So now the weight of this individual is 60 multiplied by 0.5 and actual sodium of the patient is 160 minus 140 by 140 is within the formula. So if you calculate this, you get around 4 liters per day. So please remember how to calculate the quantity of the fluid that you have to give in the treatment of hypernatremia. Please remember this formula: total body water multiplied by actual sodium minus 140 by 140. So this is a quick revision on the hyponatremia and as well as the hypernatremia. Thank you very much. See you tomorrow again with the new topic in the INI-CET revision series.